Good morning, everybody. To give proper justice to your timing and your efforts, let us start straight away. We will be judging, I suppose you all know that we'll be judging in 4 categories: content, presentation, slides, originality. So, and request to all the speakers to please stick to your time. Dr. Vivekanand is the first one to present. His topic is endophthalmitis. It's already on the screen. So you have some other talk, right?
Yeah.
Yes, so you can go ahead. Thank you.
So, good morning, everyone. So basically, today I am going to present a work which is, titled as Endophthalmitis After Pediatric Cataract Surgery, a Clinical Profile and Visual Outcomes. I do not have any financial disclosure for the slides which I am going to show here. So as we all know that, endophthalmitis is a potentially devastating condition with a poor anatomical and functional outcome. If you look at the onset, it could be an acute and, the delayed or a chronic onset. So what are the classical clinical features in acute onset? It is usually the rapid onset of vision loss and pain that they present, marked intraocular inflammation, and more virulent organisms that are responsible for causing acute endophthalmitis like Streptococcus species as well as the gram-negative organism. So as you see that pediatric endophthalmitis is a rare but a serious complication that might result from trauma, intraocular surgery, and systemic infection. So the incidence of pediatric endophthalmitis after anterior segment surgery has been quite varied range. But if you look at the Indian context, the Agarkar et al. Have a only publication which talks about the incidence which range from 0.38 to 0.45% of pediatric endophthalmitis exclusively following the pediatric cataract surgery. So how is the pediatric endophthalmitis different from the adult? So basically the innate immunity and the alteration owing to the syndromes or metabolic disorders in children, that makes a huge difference. The ocular commensal bacteria in children also differs because anaerobic organism, they keep on increasing with the advancing age. Children are often not able to articulate their symptoms and often present later in the course of the infection compared to adult. The suture related endophthalmitis is more common in children. That's what we had our own recent publication where the series of 12 patients, they had 8 patients who are because of the suture related infection. So the rationale and the purpose of this particular study is, till date the literature on pediatric endophthalmitis after cataract surgery is scarce, and to study the 12 children which we came across over a period of almost the decade, to look at their clinical presentation, clinical microbiological profile, and what are the predictors of final visual outcome. So these are the primary and secondary objectives. The study was done at Miriam Hyman Children's Eye Care Center, MTC campus, LV Prasad Eye Institute, Bhubaneswar. It was over a period of 10 years from January 2012 to December 2020. So the study design was a retrospective chart review, and appropriate statistical methods were used to analyze the data. So a standard clinical workup, treatment and post-operative care in the form of IOAB, vitreous biopsy, and as and when required pars PPV, those standard procedures were performed, and the microbiological evaluation was done in terms of microscopy by using various stains, culture, and sensitivity. So if you look at the results, the mean age and this cohort was almost 10 years with the standard deviation of 5. The males were predominant, and majority of these patients they were from a rural background. If you look at the clinical presentation, the chronic and delayed variety was more common in this cohort compared to the previous literature, and what we assume usually they present with as an acute endophthalmitis, but it seems to be the pediatric endophthalmitis is presenting as a chronic or kind of a delayed endophthalmitis. So if you look at the clinical features, I think the redness and increased watering followed by the pain is the most common presentation. And if you look at the sign, lid edema, conjunctival congestion, and then later on, like anterior chamber reaction and hypopyon are the important predominant signs they do present in a clinic. So what are the possible predisposing factor? So this is quite interesting. The kind of setup we practice, it is full of children with the tribal population. So probably this is one of the commonest predisposing factor, that is poor compliance to medication plus poor ocular hygiene, then followed by the trauma. So what is the microbiological features? I think 50% of them didn't grow any organism. So they were all culture negative, endophthalmitis. And Streptococcus pneumoniae was the commonest organism that was seen in both the groups when we cultured from the scraping as well as vitreous biopsy. So more number of bacteria were isolated in culture from the vitreous sample as compared to corneal scraping. So this is also something interesting compared to the adult endophthalmitis. So bacteria came out more from the vitreous sample compared to the corneal scrapings. Medical management, intensive topical steroids, antibiotic and mydriatics. Surgical management, you can see that the most common intervention done was IOB followed by vitreous biopsy and as and when required PPV. So if you look at the outcomes, there is an amazing trend. If you see the median interquartile range or even the mean with standard deviation, you can see that at presentation there was a gross loss of vision. However, they have shown a very good outcome at final follow-up visit. So it is contrary, like in children's, probably the outcomes are better when you actually treat them at appropriate time, and that is shown to be statistically significant. So discussion, the overall rate of endophthalmitis during the study period was 0.28%. If you see the published literature by Irwin, Shader or Good et al., it is ranging from like 0.1% to 4%. And why these differences? Why there is a big range? Is difference in demographic parameters? Yes, so I would like to what's new in this particular study. Streptococcus pneumoniae culture positive endophthalmitis is almost 50%. Delayed or late onset endophthalmitis is common in children, and suture related postoperative endophthalmitis is a slow onset caused by low virulent organism and has a good visual prognosis. Thank you.
Hello. As you said, the cause of the endophthalmitis is more suture related. So what I do in my practice, maybe you can also think about it, is the pediatric cataracts are very, very soft. So I do not enter with I do not use the keratome at all. So I use the two side ports and complete the surgery through the two side ports. Next comes the IOL insertion, is a very tricky thing. I think there are some new IOLs which are going through a very, very small incision, maybe slight increase of the side port, and if you make a little longer side port and you can push the IOL through that, you may not need a suture at all, and if you hydrate the side ports quite well, and that completes your surgery. Thank you.
I think a lot of literature is coming up in a journal like JAPOS, where even pediatric age group now people have started doing sutureless cataract surgery because of these complications.
Which were the IOLs usually used in these cases?
So these are all single piece Acrysof hydrophobic IOLs. They're all high quality IOLs.
Okay, so you needed around 2.5 2.8 incision.
Yes, 2.5 2.8.
So you need a suture, right? The 50% which you said you could not grow the culture, you thought of
didn't
means the
grew
culture
anything
came negative.
Yeah,
right?
culture came
So could it be a sterile type or TAS type of thing? There is a chance.
See, usually what happens in our institute protocol, so we follow all these patients who are taken Gron-like culture up to 4 weeks, and we label them as a negative if doesn't grow anything after 2 weeks. So till 2 weeks, we still try to look at and then correlate clinically. So what I remember, most of these patients, because they are all institute poly, so every endophthalmitis is documented very thoroughly. Even the video recordings were done for all. So none of them had a kind of feature of TAS or something like that.
But the one you gave negative was till 4 weeks negative?
Yes, all 4 weeks negative.
Okay.
I am not sure they're related to your study or not. Treatment protocol, culture negative and culture positive, anything different?
As far as outcome is concerned, I think...
No. Treatment-wise, treatment protocol. Culture negative?
No. There is no difference. We usually follow the same protocol.
IOAB, culture positive or culture negative?
Yes.
So did you find any outcome differences at the end, culture positive and culture negative?
More or less, if you see the the visual acuity improvement, majority of them recovered with better than 20/200. That is how this pediatric data seems to be something different. Otherwise, usually the Streptococcus pneumoniae happens, acute onset endophthalmitis. These patients were presented late. Despite that, also very well managed on a intensive medical therapy.
But the outcome was same.
Only 2 patients had to take a pars plana vitrectomy or.
No, his sir is asking, outcome was same whether culture negative or culture positive?
It was same. It was same.
There are
It was
statistical differences?
No statistical difference.
All right,
Yeah.
okay.
And one last question.
Just one
Are
very-
the sutures removed? Because we found that it was suture related.
We presume that is stain 0 nylon.
No. Sutures were removed in most of the suture related endophthalmitis. 3 cases that we
No,
had.
suture
in this
related
series.
you will remove. My
Yes.
question is the other way. If we feel it is the suture and if we feel it is coming on a chronic basis, means even later on. So the pediatric patients who didn't have real endo, are their sutures intact or they are
that were the
removed?
situations, where they were lost to follow up.
Okay.
And we couldn't come, they couldn't come on, the standard protocol, which we usually remove all sutures 2 weeks after the first surgery.
After 2 weeks.
First surgery, then second eye next week, and third week, both eyes suture removal.
And what is the average age of the patients, those who are...
That was 10 years. The mean
10
age was 10
So
years.
You
By this time, they develop some amount of amblyopia. That's why maybe the 200, 2 by 20 by 200.
Very unlikely, because the highest age, the duration after, the surgery was done was 29 days. So I don't think 1 month being low vision and
is going to...
causing the, endophthalmitis leading to the amblyopia is very unlikely.
Comparing with the normal group.
Oh, that would be always a bias, because there could be a plethora of developmental cataract or pure congenital cataract. So that would bias the actual visual
All
outcome.
right, thank you. Because it is outside the purview of your
Yes.
previous study.
It's-
yeah.
There are a lot of questions out of it. Comparing this one with the normal things, visual outcome.
Yeah.
You said it is 2 by 200, but what about the normal eyes?
Yeah.
Non-endophthalmic eyes. Please next.
Fine. Yeah.
Thank you.
Thank you. So I think now we go as per the order.
I think number 1, Dr.
Yes.
Jebinath is not here.
Dr. Jebinath is not there. Okay.
We have been informed.
So first is not there. Third one was bigger. Third done. First
Third
is
done.
not there. So
Second
now
is
we. It's
Yeah.
Dr. Supriya Samak. Her topic is safety and clinical outcomes. You are Supriya, right?
Yes, ma'am.
Yeah.
Good morning, everyone. My name is Dr. Supriya Samakshi Ganesh. Thank you to the esteemed panel for this opportunity. Today, I'll be talking about safety and clinical outcomes of a new anterior capsule fixated toric IOL with swivel haptics. So, the most common pitfalls of present-day IOLs is, first of all, the effective lens position. Then we always look at the rotational stability of toric lenses, and the fact that premium or toric lenses cannot be used after complications like PC rent, zonular dehiscence, etc., aphakia, etc. No premium IOLs are present for aphakia, and many rings and steps in multifocal lenses cause photic phenomenon. So there are a few existing solutions for capsulotomy fixated IOL designs, the first of which is the bag in the lens IOL or the Morcher IOL. For this, a perfect 4.8 mm rhexis, preferably a femtorhexis, is required, and a posterior capsulotomy is required. So the anterior and posterior capsulotomy are captured in the IOL. So it's called the bag in the lens IOL. This has a groove in the periphery. The other lens is the Masket IOL design. This also has a peripheral groove and requires a femtocapsulotomy of 4.8 mm, and failure to capture the capsulotomy can cause a capsular block. There's also the Femtis IOL, which has 2 haptics. The inner haptics clip on to the capsule, and this also requires a femtocapsulotomy of 4.8 mm, and this can cause the haptics can clip onto the iris, which can cause iris tissue damage. So each of these lenses, which are the current solutions, require a femtocapsulotomy and have other drawbacks. So the new design of the swivel haptic IOL is as follows. The lens looks like this. It's a single piece open loop hydrophobic acrylic IOL, which has a 6 mm aspheric optic with 13 mm overall diameter and 2 extra haptics, 2 swivel haptics of 2.5 millimeters each, made up of a proprietary material, which swivel over a pivot. This lens has an A constant of 117.1 due to the anterior effective lens position, and it has a 360-degree square edge. So 8 eyes of 6 patients fulfilling inclusion and exclusion criteria were included in the study. The inclusion criteria was patients with cortical cataract or nuclear sclerosis with corneal astigmatism of more than 1.5 diopters because it's a toric lens, informed consent and willingness to participate in follow-up visits. Exclusion criteria were mature intumescent cataract, subluxated lenses, pseudoexfoliation, any other pathology. This is a short video of the surgical procedure. You can see the swivel haptics lens. Before loading the lens, we always check that the swivel is moving. There is a hole at the end of the swivel haptics. So this is normally loaded in a backloading cartridge with the swivel haptics closed. This is a regular backloading cartridge in which it's loaded and it's implanted in the lens. Once it's implanted in the anterior chamber, it's put into the bag and the swivel haptics are opened up above the capsulotomy to capture the capsulotomy to the swivel haptics. Here the advantage is that you don't need a perfect 4.8 mm rhexis. You can even do a manual capsulorhexis, and the visco is easily removed from even under the lens. You can see that it is aligned and centered quite well. So our results, the pre-op astigmatism average, the mean pre-op astigmatism was about -1.92, and post-operatively we found that the mean was 0.21 plus or minus 0.33, and the spherical equivalent is 0.27 plus or minus 0.42, which shows good visual outcomes. The mean post-op IOP on day 1 was 15 across, and 1 month post-operatively, none of these eyes showed any signs of pigment dispersion on gonioscopy. The mean post-operative ACD at 1 month was 4.067. UBM and slit lamp photography were done in all cases and showed a stable IOL with swivel haptics in position. All cases showed the toric IOL in the intended axis at post-op 1 month with no IOL rotation for toric lenses. No patients reported any symptoms of dysphotopsia, and there were no intraoperative complications in any of the 8 cases. So the potential advantages of this lens is the rotational stability. A manual or a femtocapsulotomy can be done, better centration, less tilt. No special instruments or training is required, no special equipment is required. Here you see a UBM with a relatively anterior and fixed effective lens position. So we can actually determine the effective lens position for better visual outcomes, less negative dysphotopsia. And even in complex cases such as PC rent with intact rhexis, this can be used. The holes in the haptic allow for scleral fixation with proline, and even with zonular dialysis and aphakia, this lens can be used for scleral fixation.
Your time is done, actually. Yeah.
All right. Thank you.
Thank you. So you have any question? I do have. Yeah.
What is the particular indication for use of this lens out of the standard available lenses?
So this lens can be used in routine cases. In any cases it can be used. The speciality of this lens is, first of all, for toric lenses, one of the main drawbacks is the rotational stability of toric lenses. So this lens, since it fixates to the anterior capsule, there's no chance for rotation of the lens in the bag. And the other indications would be if we're using toric IOLs.
My question is simple. Will you use this lens routinely for any toric implantation?
Yes, sir.
Forgetting other lenses available at the moment?
Yes, sir. That is the idea, that we can use this routinely not only for toric lenses but for all lenses, because we can determine the effective lens position. That is the main part of the biometry that till now we have not been able to actually determine, which causes that.
That means apart from rotational stability, you say that as it fixated on the taking support on the anterior capsule.
Yes, sir.
So effective lens position is always fixed.
Yes, sir.
So your A constant is always giving 7.1.
Yes, sir.
That is the reason you want to replace all other standard lenses with this.
Yes, sir.
That's it.
Yes.
2 points. What are the negative points of this lens?
The negative.
You gave the advantages. You didn't say
Yes, ma'am.
disadvantages.
One of the drawbacks of the study is that we have only implanted it in a very few eyes.
8 eyes. Right?
Yes, ma'am, 8 eyes. So previously, a study was done with a non-toric version of this lens, for which we did a study with 30 eyes, which gave good results.
How
but
long is the follow-up? The longest
for the
follow-up?
first study was a 6-month follow-up.
Only.
Yes, ma'am. Post which the paper was published, but now we have longer follow-up of up to 2 years. And with this lens, the follow-up has been quite short. It's just 1 month post-operatively.
That is
we
the
are still
toric
collecting.
part.
Yes, ma'am. That's
Okay.
the drawback of the study. And about the lens itself, it takes a little bit longer because you have to open up the swivel haptics intraoperatively and
No,
fix it
that's
to the
okay.
capsule. So the time increases.
Maybe half a minute.
Yes.
That's really not the problem.
Yes.
That's not a problem. 2 more things in that case. Does it give you iris chafing like
No,
from?
ma'am. So all the
yeah.
we've performed.
It doesn't rub on
gonioscopy.
the posterior part of the
The
iris.
material you said is a proprietary material. That
Yes.
means whether it is a proline or anything you can't divulge.
It is the company has told us that it's a material that is similar to what is used in spinal surgeries, but it is a proprietary material from the company, which right now is not yet available. That information is not available. But in our data, we have found that there's no pigment dispersion, iris chafing, increased IOP, because we've done serial gonioscopy and checked that.
Okay. And in the longest follow-up of the non-toric version,
Yes, ma'am.
is there any rotation seen? Because
ma'am.
from the
No decentration,
you will be
no
able to
tilt.
see, right?
Yes, ma'am. No decentration, no tilt, no rotation in any of the cases in the initial study. And so far, with the 1 month follow-up for these cases, there has not been any rotation.
Yes.
Is the how do we get it? We also would like to try.
So this is in development still.
Okay.
We are expecting to do. The new lenses have come in. The toric lenses have come in, and we are implanting the lenses. It
Okay.
should be released in about 12 to 18 months' time, is what we are expecting.
Any companies doing this job?
It's from biotech.
Biotech.
So,
Okay.
yes.
Thank you.
Dr. Ganesh uses
Yes,
it, right?
yes.
Because before a year I had seen the same non-toric
Yes.
thing that he had presented.
Yes.
Okay.
Thank you. Thank you very much.
So next we call upon Dr. Sheetal Brar. Her topic is feasibility and safety of a safe. Now we'll be taking in line. Both. Yes, Dr. Sheetal, you can go ahead. Yeah, you are Dr. Sheetal, right?
Yes,
Yeah,
yes.
she's.
Good morning, respected chairpersons and dear friends. Today I'll be talking about a new device, which is a safety device, a rescue temporary device, which can be used to improve safety in PCR occurring during phacoemulsification and prevent the risk of nucleus drop. Myself and my co-author, Dr. Sri Ganesh, have no relevant financial disclosures in this presentation. So, unarguably, out of all the complications of phaco, posterior capsule rupture or PCR is one of the most devastating complication because it is also associated with other complications such as vitreous loss, nucleus or fragment drop, which invariably need a retinal intervention, which also leads to collateral damage in the form of CME, uveitis, secondary glaucoma, also challenges with IOL placement. And all this eventually will lead to delayed visual rehabilitation for the patient and increased overall cost of the treatment. So if PCR happens during ECC or SICS, we know it's not a big problem. It's easy to manage. There's already a big wound and you can prolapse the nucleus out. But when PCR occurs during phacoemulsification and fragments are there in the anterior chamber and you want to manage it through a small wound, this is a big challenge. And this also entails a high risk of nucleus drop or fragment drop. So presenting to you a new device, we call it as safety net device, we have developed at Netradhama Eye Hospital. This is a new temporary rescue device made of biocompatible, implantable, foldable hydrophilic acrylic material. It is circular in shape and has an overall diameter of 7.5 millimeters. So on the left side, you see the version 1 of the device, which is like a net-like structure with square-shaped holes. So the holes were square-shaped with a size of 0.8 into 0.8 millimeters. On the right side is the version 2, which we are currently using. This is a little different. You can see that there are 4 bigger holes in the periphery, orthogonal 90 degrees to each other, and each of these holes is 1 millimeters in size, and the rest of the device is filled with smaller holes of 0.45 millimeters, and the overall thickness of the device is 0.2 millimeters. So let's look at the practical use of this device. So this is a case where I had a PCR during phacoemulsification. The cataract grade is also almost grade 3 to 4 here, and so here we see the practical utility of this device. So first, before implanting, if there is any vitreous, you must clear the vitreous, and then bring all the pieces. First you need to bring the pieces above the iris plane and then clear the vitreous, and then you can load this device in a 2.8, a regular 2.8 millimeter injector, and you can implant it over the iris and under the fragments. So and then you can adjust it using a Sinskey hook, and now you need to fix this device. You cannot use it without fixing, so you need iris hooks to fixate the device. And so you can make 3 paracenteses and fix the device using the 3 iris hooks. Make sure that you fix it properly, and you just most of the times need 3 points of fixation instead of 4, because on the 4th side the fragments themselves will stabilize the chamber. So now once the device is fixed, you can easily go ahead and emulsify the fragments with the phacoemulsification itself. So here you do not actually have to increase the size of the wound, and you can manage the whole PCR without the risk of having a nucleus or fragment drop with ease. And here you can see this is the last fragment being removed. And use of this device is also quite easy and simple. So once its job is done, you can just remove the hooks, and using any forceps you can take it out. And then now you can easily clear the vitreous properly. You can do a proper cortical cleanup, and then you can assess the situation properly, and then decide the type of lens which you want to use. So this is another case I'll quickly show. This is the version 2 being used. So here you can see almost 50% of the nucleus is there in the chamber, and so we inject our safety device under the fragment and over the iris, and we have those 4 holes, and in the 4 holes we take the iris hooks inside and fix the device at 3 points again. And once the device is fixed, now our job is easy, so we can just go ahead and emulsify the fragment. So indications would be any situation in phaco with potential risk of nucleus or fragment drop, gross zonular dialysis where bag is not salvageable, or a case of nucleus drop being handled by a retina colleague where there is no access to fragmentome. Prerequisites will be definitely you need some amount of ambidextrity and familiarity with the use of iris hooks, must be secure at 3 points, and if there is vitreous, you need to clear the vitreous before inserting the device. Contraindications or caution: if there is a lot of, say, more than 3/4 of the nucleus is present and there is no space available, then it may be difficult to insert it under the fragment or the nucleus. If the nuclear fragment is very dense, hard and brown, endothelial count is less, and if the pupil is very widely dilated, sometimes you have those traumatic cataracts where the pupil is very widely dilated, so there also it may not be a good idea to use this device. And if there is a sphincter damage or associated iridodialysis again, and if there is poor visibility. So we have used this device in about 24 eyes in our institute. 5 eyes had PCR in the private.
6 minutes are over.
So I'll just
our discussion time is done.
Conclude that safety net device may be a useful device to prevent nucleus drop and its complications during phaco. Its timely and judicious use may prevent devastating complications of nucleus drop.
Yeah.
And retinal surgery.
I request everyone to please stick to your time, because then our discussion time goes away and you also land up with some minus points. First thing is, it doesn't allow the fragments to go back or drop,
Yes,
but
ma'am.
it will keep allowing the vitreous to come out.
No, ma'am. the first thing is that we have to first recognize the PCR. The moment we recognize the PCR, we normally what happens is we
No, will it allow the vitreous to come out? Logically, it will.
through the net.
Through the net, the vitreous is bound to come, no?
It can come.
It is bound to come.
But the thing is that we need to first do a...
No, what we need, that's fine, but it can come, right? See, the wrong message should not go. It doesn't allow the piece to drop is perfectly
Yes.
fine. It's very logical.
Yes.
But it definitely, the vitreous is exposed to all your management and suction. And the less the management done with vitreous means less you touch is always better. And do you think, suppose you have a VR option, that you have a drop or you are going to have a drop and a VR surgeon can manage it, and on the other hand you have this net, you would go for a net?
Yes, ma'am.
You would go for a net
Definitely.
even if the vitreous keeps coming.
Ma'am, it's vitreous we
two
will
points
anyways
which
have to
went
manage.
against this. The whole purpose of that net is only to not allow a drop. But
Not
it is
allow a drop
not
and
giving
prevent a major
due-
retina
One
surgery.
minute. It is not giving any respect to vitreous. We are increasing the wounds. We are making 3 more extra wounds. That is one thing which normally, if this is going to come out, why make more and more wounds? The best thing is to close it with proper anterior vitrectomy, not anything in the AC. AC should be without vitreous, and hand over the eye to a VR is the best option. In general, that is the gold standard, we believe,
Ma'am,
right?
yeah.
Okay, no, that's okay. It's just, I'm not contradicting you. It's
My
just
question is that how it is advantageous over IOL scaffolding?
Yes. So IOL scaffold technique, in that technique you use a 3-piece lens to tamponade the piece.
Not necessary. If you have got an intact bag,
That's in the intact bag, sir.
Yeah.
Here the
Just
indication is very
PCTR,
specific,
PCB,
where you already have an intraoperative PCR. So when you have PCR, you anyways have a very high risk of nucleus fragments dropping. So this is a device which can be used to prevent the drop. Also through a small incision, maintaining a small incision. Now you may ask me that it is easy to extend the corneal wound or make a scleral tunnel and prolapse it out, rather than using this device. But again, in that, when we are prolapsing the nucleus, there's already because this is a very special situation. The PCR has already occurred and there is already vitreous. So when we are prolapsing the nucleus through a bigger corneal wound, then we are also creating
No.
lots of corneal
I'll just put one
wound-related
point.
complications.
I will
1 minute,
scaffolding is
Dr.
not
Chitaya, you are contradicting your own slide. You said in ECCE and SICS, it is much easier to
Easier
manage.
to remove the nucleus.
It is going to bring that much vitreous
Easier to
also.
remove the nucleus.
Anyway, that's fine. So the
but
point is
preventing
taken.
the
That's done. Okay.
preventing
Sir,
the
you
drop.
have some.
Okay, that's all.
That was the idea. That is the
I would support doctor that if there is an anterior capsule is round and perfect, so what we normally do is we put a 3-piece IOL on the anterior capsule. It will do almost the same thing what your mesh is doing, and I think that is little more posteriorly placed compared to your mesh which is on the iris. So we are actually working much more closer to the endothelium rather than IOL on the anterior capsule. So the distance between the endothelium to your phaco tip is much less and than the other one.
Even
So what
with
do
the
you think?
IOL scaffold, the pieces are over the iris and
That's
they're
right.
close to the endothelium.
Right,
The
right.
problem with the IOL scaffold is that once you put the IOL under the fragments, then doing a proper vitrectomy and cortical cleanup is difficult.
That's
So
true.
a normal surgeon will have to, it is difficult for them to do it through the anterior route. It's better to do it through pars plana vitrectomy, which not everybody is able to
But
do.
I was seeing that your
Also when you are eating up the fragments over the IOL, you will have to use a dialer and keep shifting the lens so that it covers the pupil, because the size of the optic is much smaller. It is not adequate to cover the whole pupil. So we will always be.
Do you think pupil also helps constricting? You have to bring all the all the cataract pieces in front. Can you constrict the pupil and bring about the similar effect? It can. Anyway, we end the topic there. We don't discuss further. Thank you, Dr. Sheetal. We don't take further time, please. Thank you so much. Yes. Next is Dr. Bindia. At 5 minutes, can we have a buzzer so that they know that their time is over? Okay?
5 minutes.
5 minutes. The buzzer is coming at 6 minutes. So we need 1 minute after that.
Please, Vindhya.
Yes. Go ahead, Dr. Bindia.
So, my topic is on the effect of posterior capsulotomy size on refraction, IOP, and macular thickness. So, we all know that posterior capsular opacification is one of the most common complications of cataract surgery, which causes secondary visual loss, glare, and diplopia. It can be treated by Nd:YAG laser capsulotomy, but complications of the procedure include IOL dislocation, cystoid macular edema, increased IOP, pitting, etc. The optimal size determined by the surgeon is based on many factors, which depend upon scotopic pupil size and size of IOL. So the aim of the study is to see the influence of size of capsulotomy on spherical equivalent, IOP, and macular thickness. Coming to the material and methods, it's a prospective study. We included pseudophakic eyes with uncomplicated cataract surgery with PCIOL implantation and BCVA less than 6/9 who were treated by Nd:YAG laser posterior capsulotomy, and sample size was 50, and we excluded patients diagnosed with glaucoma, steroid responders, corneal opacities, uveitis, retinal diseases, etc. So methods, we took a detailed history and examination, and follow-up was done at 1 week, 4 week, and 12 weeks. So deciding capsulotomy size. It was decided by the surgeon based on the fact that it should be similar or larger than pupil's diameter in the scotopic environment. And it was measured with the help of reticule of slit lamp before the dilatation of pupil. We performed YAG cap after putting a drop of tropicum at 1%, and we applied topical proparacaine drops, and laser shots were delivered at the level of posterior capsule. After doing the capsulotomy, post-op drops were prescribed like bremonidine and lotiprid. Patients were basically divided into two groups. Group 1 consists of 24 patients with capsulotomy size less than 4.5, and Group 2 consists of 26 patients with capsulotomy size greater than 4.5. And after that, the changes due to laser capsulotomy in spherical equivalent, BCVA, IOP, and central macular thickness were studied. So we'll come directly to results. Group 1, that is less than 4.5 millimeter, it included 48% of the participant, and Group 2 included 52% of the participants. Mean age, it was 62.84 plus or minus 10.46. 40% were females and 60% were males. So it was found that in both the groups, mean IOP, it increased in the first week of follow-up. But at 1 month and 3 month follow-up, the mean IOP decreased in both the groups. Similarly, macular thickness also, in the first week, there was an increase in both the groups. But in 1 month and 3 month follow-up, it decreased. And it was found that IOP increase and macular thickness increase was more in Group 2 than in Group 1. We also compared power, shots, and total energy. Only difference among the two groups was that in Group 2, the number of shots required was more, obviously, because the size of the capsulotomy is greater than 4.5, which required more shots. Spherical equivalent, it was found that there was a hyperopic shift in Group 1 and there was a myopic shift in Group 2. So coming directly to the discussion, there was a statistically significant and stable improvement in BCVA after YAG cap in two groups over the whole period of follow-up. And also in Group 1, we saw there is a hyperopic shift, and Group 2, there is a myopic shift. And the increase of mean IOP and mean macular thickness, it increased at the first week and decreased subsequently, and both the increase was more in Group 2 than in Group 1. So these are my references. So thus concluding that laser capsulotomy is the gold standard treatment for PCO because it can be done in a polyclinic condition and improves the visual outcome. Our treatment strategy and recommendation is that the opening should be larger than the size of pupil in scotopic conditions. Thank you.
Thank you for
Thank you.
Kindly.
Hello. Just one query, why there is a shift of different type of shift in both the capsulotomy?
So basically, we did this study so that whether to know whether a small size or big size is appropriate. But doing this study, we can't predict in all patients. It depends upon the scotopic pupil size, obviously. And also, like asking me personally, it will be better. In many cases, we found that if we are putting a capsulotomy size so small like 3 mm and all, the patients end up in the subsequent follow-ups, tags, capsulotomy tags will be there, and BCVA is not improving. So asking me personally, it will be better if we put a slight bigger capsulotomy, because IOP increase, macular thickness increase is there in first week, more in group 2, but in the subsequent follow-ups we can see that it is becoming
But
correct.
his question was the myopic and hyperopic shifts.
Okay. Oh, what was it?
I'm giving you the clue how it happens. It might happen. It is
Sir, hyperopic shift happens because of tilt of IOL posteriorly.
That's I'm telling you. If you could have measured the anterior chamber depth from the anterior lens surface to the cornea before and after with the bigger size, there is more vitreous thrust and pushes.
Yes, sir.
This could be the clue. Exactly, ELP. That is the question he asked, and I've given you the answer.
Oh, okay.
So you can study that one, anterior chamber depth. In
In the
both
subsequent
groups.
studies, we will have to include.
Not in the beginning, but when it stabilizes.
Okay, sir.
Then, yeah, thank you. You are the only author, right?
Yes, sir.
Fine.
But your author and co-author same name. Bindyasi. I don't know whether she is different. Author and presenting author.
Actually, a presenting author was my guide, but she was not able to attend the conference.
His name was in the.
I have put in
Is
the.
nothing
No, here only your name is there as author. Again, as co-author, it is Dr. Bindya.
She was presenting author only.
there. All right, no problem.
Done.
You could have given her name
And-
or his name as a co-author.
Oh,
You are too. That's it is not to criticize you.
Okay.
It is nothing to criticize you, to encourage you. Put your guide name in there as a co-author, no problem.
Yes, sir. Okay. Thank you, sir.
Okay, thank you.
Good content.
Yes.
Simple.
So next is Dr. Utkarsh. Yes, Dr. Utkarsh. Come.
Good afternoon, everyone. I'm presenting my paper on comparison of IOL 700 and manual keratometry in visual outcome on monofocal toricoil implantation. Introduction. The refractive power of the eye is determined by the cornea and the lens, whenever there is cataract formation, there is decrease in vision, and cataract surgery is the most commonly done surgery worldwide. Nearly 60% of cataractous eyes have at least 0.75 diopter of corneal astigmatism, and out of them 40% of those have corneal astigmatism of 1 diopter or more. And not correcting the astigmatism component at the time of surgery leads to failure of achieving spectacle independency. Whereas studies have shown that 20 to 28% of eyes have total corneal astigmatism different from anterior corneal astigmatism by more than 0.5 diopter or more than 10 degrees. This study evaluates the what differences are seen in the final outcome of toricoil implantation if we consider total, that is anterior plus posterior astigmatism by almost 700 or only anterior corneal astigmatism by manual keratometer. This was a prospective intervention study. It included the 40 eyes of 40 patients. Inclusion criteria was immature cataract or astigmatism of more than or equal to 1.5 diopter. And the exclusion criteria was mature, hypermature, or traumatic cataract. If there was any corneal opacity or any posterior segment pathology or any issue of amblyopia or trauma. Patients were randomized into 2 groups. After the basic investigations, the keratometry was done by in group A, it was done by IOL 700, and the group B, it was done by manual keratometry. And the biometry was done by IOL 700 in both the groups. On the basis of that, surgery was done and toricoil were implanted, and all surgeries were done by the single surgeon. In the results, the 40 eyes of 40 patients were included. The group A, that is all master 700, in that mean visual acuity was 0.13 logmar, and the group B, that is manual keratometry, it was 0.20 logmar, and the statistical inference was non-significant. In terms of residual astigmatism, in the oil master group, it was 0.13 diopter. In the group B, it was 0.59 diopter, and it was statistically significant. And in terms of keratometric error, in the group A, it was 0.105, and the group B, it was 0.131, and it was non-significant. On comparing the vector components of all 40 patients by oil master and manual keratometry, the J0 and J45, the differences between them were non-significant. Discussion. As a result of technological developments in the cataract surgery, it is now very minimal invasive and increasing significance or effective outcomes. To optimize the visual outcomes and minimize spectacle dependence, both the spherical and cylindrical components of the refractive error must be addressed. Our results were similar to Ailmeger et al., who in 2013 described in their study about J0 and J45 with oil master and manual keratometry, and in their results, the mean difference was statistically insignificant. Hassan Razmo in the 2017 blinded toric oil in the 55 eyes of 45 patients, and in the terms of uncorrected visual acuity, their difference was also insignificant. Menuk Chang et al. In 2014 introduced the term keratometric error. He said that since the toricity of IOL place also influences the post-operative astigmatism, so they hypothesized that this would provide the greatest accuracy in residual astigmatism determination. In 2014, they implanted toric oils in 25 eyes with measurements from manual keratometer, oil master, pentacam, and auto keratometer. Their results showed that manual keratometer was the most accurate, but the differences between the instruments were not statistically significant. To conclude, overall, our study says that oil master 700 and manual keratometry gave the comparable results. While also considering the cost efficiency, it comes down to user affordability. If oil master 700 is available, it should be preferred for more precise results. If not, manual keratometry is already giving the almost equivalent results. Thank you.
First thing is you are not non-ratified member, they have mentioned, so we'll not be judging you, right? Yeah.
So questions must be there.
Yes.
You have after doing the keratometry, you implanted toric oil in those cases. Then you compared.
Yeah, I have compared toric oil in the both the cases.
Which oil we compare? Toric oil.
Alcon monofocal toric oil.
So all having same oil.
No, there was not a same IOL. See, our inclusion criteria was the astigmatism study more than 1.5 diopter. So our patients were from 1.5 to almost 5 diopters.
Same make IOL.
Yeah, same maker.
A few questions. Number one, the posterior keratometry, how much it contribute in the total keratometry value?
See,
because IOL Master 700 gives both and give you the ultimate or is the total corneal curvature.
Yes, sir.
And the manual is giving only the anterior.
See, the various studies have shown that in 20 to 28% cases, the total corneal astigmatism is different from anterior corneal astigmatism. It can increase the total amount of astigmatism, or it can also decrease the amount of astigmatism. But in
your study, in the keratometric values, what is the difference between the two groups? Average difference.
We have seen the differences were there, but we have not studied what is the exact.
No, the difference was significant enough that. See what he is saying, you have only the anterior keratometry readings and you have both anterior and posterior. So was it significant enough? That's why you did the study.
In the preoperative data, we did not compare it, but in the results, the residual astigmatism was the significant difference, but in all other parameters,
But ultimately, you are doing the axial length by the IOL master.
axial length by the IOL master.
All right, so you cannot get rid of IOL.
I have a question.
700.
Just a minute.
Now,
Yes.
we tried to do.
Yes, compared, they compared me one time.
Yeah. I have the same question.
Okay, thanks.
See, you actually said that it is due to that non-availability of the machine or the manual keratometry you are doing, but you are putting the same value again in an IOL master. So you have an IOL master, that means.
And that means he cannot get rid of.
I wanted to stable the other factors so that
Okay.
It is the IOL master 7-hour anterior, and they also suggest to keep one manual keratometer handy with you. In
yes,
cases of
because of
much
chromatic cataract, in those
controversy,
it doesn't
you
work.
go to the final verdict from the manual keratometer.
Yes, when you have 2-3 different readings for keratometry from, say, you have done a pentacam, it is for
Anterior.
post-refractive cataracts. So you do have different, and then you are all confused. So one more thing can be added. And you have compared only the keratometry part. But anyway, we need other things. That's perfectly fine.
There have been studies which have shown that in terms of biometry, but this was the first one, I think, in which we
For the
compared
keratometry.
Be
That's
rectified
right.
now and do the study on your own
Thank you, sir.
shoulder.
Yeah.
And prepare all the questions ready for your next presentation.
Thank you, sir.
Thank you.
Last one.
Next, no, there's one more page.
one more.
Dr. Mithun is the next.
Two more.
So, respected chair and delegates, wish you all a very good afternoon. So, today's my talk is on flow capsulorhexis, a safe technique in hypermature cataract. So, attainment of a CCC is considered a challenge, particularly for the intumescent type. And in literature, the incidence of incomplete capsulorhexis in white cataracts ranges from 3 to 28%. Rarely we encounter with this complication, that is sometimes the Argentinian flag sign. So many techniques have been already advised to perform capsulorhexis in hypermature cataracts, including the needle decompression technique, which is more popular, I feel, like initially introduced by Bhattacharya et al., where we use a 26 gauge needle to make a nick in the center, aspirate the liquefied cortex material, and then proceed with the conventional rhexis. Then we have the phaco capsulotomy using the phaco probe, 2-stage capsulorhexis, CanVac technique, and vacuum rhexis using syringe and vacuum to control the rhexis. And we have the sewing needle microcapsulotom also, where we use a similar technique of needle decompression. And then the latest technologies, that is femtosecond based capsulotomy and septorhexis. So in the present study, we describe a new technique, that is flow capsulorhexis in white intumescent or no intumescent cataracts, and compare it with the standard needle decompression rhexis. So why I choose needle decompression rhexis was because that is the one which I used to do more often before this technique. So this was a single center 2-sturgeon retrospective study, and we analyzed the data of patients between July 2021 and June 2022, 1 year. Group 1 had patients who had undergone flow rhexis, and group 2 with patients who had undergone needle decompression rhexis. So this is the surgical technique.
Video not playing.
So basically we attach the tube and cystitome to the infusion line of the balance salt solution, and we actually keep the flow open. So basically you just need the infusion line.
Can someone help, please? The video is not playing.
You have video with you?
Yes, I have kept it
Yes.
actually separately.
Just play.
Separate the video.
It is all on the video.
Yeah.
Nothing to listen.
So it's playing.
Hello. Hello. At one time they have given me 3 slots. So those 2 people are regular.
Right. It's very popular.
I sent 3 times.
So here we attach the tube and cystitome to the infusion line of balanced salt solution. So you just don't need any extra instruments. You just attach the needle to the.
It is long before tried and failed. I can remember 25 years ago in UK.
Yes, I played
This
from
lady
here.
was doing this. It was mature cataract is not working.
Idea is to pressurize the gel.
So we just attach it to the infusion line of the BSS, and the flow is kept open. Now we enter with the flow open actually. So initially once we make the nick, the continuous flow of fluid automatically washes out the liquefied cortex material. Here only we have a minimal egress of fluid. Then once the liquefied cortex is washed away, then we lift the flap and we rotate it. The other advantage is that the flow is continuously kept open so that the anterior chamber is maintained. So it doesn't allow the anterior chamber to collapse. And then we can proceed it without any difficulties. Also the visualization will not be hampered, because what I believe is when the visco which gets mixed up with the liquefied cortex, that is basically hampers the visualization. So then here I complete the rexes, and it's almost like well centered and circular. There's one more case where you have a lot of liquefied cortex material. Again, the flow is kept open. You can see the BS is dripping drop by drop, and there's a lot of liquefied cortex. So once it is over, then we actually proceed with the rexes, and actually it completes the rexes. So we have different techniques like I discussed, which was already described in literature. Now we describe this new technique, that is flow capsulorhexis, and the advantages include its fastness, minimal or nil use of OVD, no need of additional instruments, cost effective and easy to master. I would like to show the results. Like we have compared it between two groups including 608 eyes of 420 patients, which were demographically similar. And when it comes to the outcome measures, the completion time of CCC and times of OVD supplement was comparatively less in group 1 and success rate was high in group 1. Though we encountered a couple of cases with peripheral radial tear out, there was no complications. Group 2 had a couple of complications, but that was not related to the capsulorhexis technique at all. So this is one case where there was a peripheral radial tear out actually. Yeah, so once we start the rexes, the fluid is getting washed away. And now you can see a small radial extension when it comes to this point. Now, so I've used the ILM peeling forceps and the scissors to continue the rexes, but this will be considered not as a success criteria because we have used multiple techniques.
Actually, we have
so to conclude, this technique is economical, it takes less surgical time and is easy to master and can be used in white and hypermature cataracts. Thank you.
Okay. The positive point what I am seeing in your slide is that it definitely increases the visibility. As we puncture the anterior capsule, all the white materials comes into the AC and we cannot see where is the edge of the capsulorhexis we are going to turn. And that's the good point in yours. But I have a small doubt. See, as your fluid is pushing into the anterior chamber, maybe the fluid and the visco is mixing and you are losing the fluid through your main wound, and it may reduce the anterior chamber depth and maybe it can result in a runaway of your lexis.
Yes, sir. That's what, like, it's not 100% safe. Like even in our
have you used visco before?
Yes, sir. That we have
after visco you use the flow.
Most of the time we never used to use visco.
So there's no visco. That's what I felt.
Yeah,
that's why.
Because only in one case where we had to, because when we feel the intralanuclear pressure is coming up and when we have that gut feeling.
Question. Suppose you have the whole problem is when there is a bulge. When it is
then
convex,
we will use the visco.
That is the one which is going to. Otherwise,
otherwise
most of the times it doesn't go
away.
That is the bulging convex anterior capsule which is going to not give you a single second. Even if you keep washing, that will tear off, right? Right. Exactly. So there it is not going to help.
One of the advantages is that
have to go with a heavy visco to first flatten it.
Yeah, actually in this case we have used HPMC only, ma'am, in this study.
But these were not the bulging types. These were hypermature.
Like we had both the bulging and the.
In any of these cases, it was the bulging type. It was.
No, we had
the third one was actually a little bulging and it ran away.
Yeah, ma'am. Actually, it was like a retrospective study. So we had included both intumescent and non-intumescent. But due to a long number of cases, actually we couldn't actually classify it. Actually,
Unless you increase the intraocular pressure more than the intralenticular pressure,
It's not going to work.
is very difficult to manage.
Yes, sir.
Just one
Agree.
tip. What I have been doing in most of the cases in
Yes, sir,
hypomation
please.
cataract, I use infusion cannula from the side port and use simple needle capsulorhexis from the other side. So
Yes, sir.
it maintains the
Ambient
intraocular pressure
extremity. Yes,
very
sir.
well, and it actually flattens the fold
Yes, sir.
capsule over the
Yes, sir,
axis,
definitely,
and then that
definitely.
I do, and I do all the phaco with the
Yes, sir.
infusion only.
There are different techniques which works
there are-
best in different
Some are
times.
happy with
Yes,
the
sir.
anti-chamber
Yes, ma'am.
maintenance. We have done this, what using even in our residency, and we found that the cases which are going to trouble us,
Yes,
there
ma'am.
it doesn't work. There
Yes,
it
ma'am.
doesn't
That
work.
definitely
Yeah.
it's not 100% safe.
It doesn't work
Yeah.
there. That's right. Okay.
Thank you,
Any
ma'am.
more? Fine. Thank you. So we have two more to go. Next is Dr. Saurabh Patpar. Then welcome, sir.
Thank you, ma'am. Thank you.
Looking forward to learn something from you.
Thank you. So my paper is about innovative method of sidewave sculpting for nucleotomy in cases of hard posterior polar cataracts. I am the presenting author, Dr. Saurabh Patpar from Nandadip Eye Hospital. So as we know that PPC have always been a challenge to cataract surgeon because there is always higher propensity for posterior capsular rupture, and that may be because there is a possible adherence of the PPCs to the posterior capsule. So incidence of complication have definitely reduced, but still we have to plan a strategy for that. Now these are the popular strategies which have been already described. For example, to avoid a large anterior CCC so that we have a good optic capture, we can do a oval CCC as well. Avoid deepening or shallowing of the anterior chamber during the procedure. Avoid hydrodissection but perform hydrodelineation. There should be no nucleus rotation during the maneuver as far as possible. Use low vacuum, low flow rate, and avoid any capsular polishing at the end. In this study, we use Daljit Singh classification of posterior polar cataract, where type 1, 2, and 3 are showing different characteristic of posterior polar cataract. But in this study, we have included type 4, which is combination of different signs along with nuclear sclerotic cataract. Now, purpose is to introduce an innovative method of sideways sculpting for nucleus management in cases of hard posterior polar cataract. We included posterior polar cataract with nucleus crosses of grade 2 and above. We excluded the softer grades of cataract less than grade 2. The types of study was retrospective analysis over last 4 years. So sample size was 17 eyes from 17 patients who underwent surgery for cataract surgery with PPC. Single surgeon performed all the operations and sideways sculpting method is used. So in order to show the sideways sculpting method, I would rather show video because it's more of a more descriptive of the technique that I'm going to use. It's stopping here. Can you just start the video? You can start without the slideshow, that is also fine. Yeah, okay. So in this video, I'll be describing this innovative technique of sideways sculpting for grade 2 and above nucleus sclerosis of posterior polar cataract. This is a novel technique, has not been described in literature yet. So this is a soft gate cataract, which is very easy, I would say, as compared to a nucleus sclerotic cataract, because here we can go layer by layer and just aspirate the nucleus without need of any rotation of the nucleus. And this is what we commonly use because these are the cases which we commonly encounter where PPC is without much of a nucleus sclerosis. But what to do with PPC but a denser nucleus, it always poses a challenge. So in such cases, we can use this technique. So here, first we do a standard trench, which is a straight trench, which has been described. And then after making that first good deep at a good depth trench, what we do is we move the phacoprobe sideways without any rotation of the nucleus. So we make sideways sculpting of the remaining two heminuclei on both sides. So it's like divide and conquer method, but without any nucleus rotation. You can call it in situ quadrant and the 4-quadrant method. And once we have this 4-quadrant, we very gently separate these 4 quadrants and emulsify. Just watch this in action. So this is the first trench which is done. A good deep depth of trench is needed, and now I am moving the tip sideways so that I create side trenches, so that we have this plus sign, this classic divide and conquer sign, and then we split this nucleus into 4 parts. Okay, you can see the central part is still not completely split, and then you can take out these pieces one by one without need of any rotation of the nucleus, and just finish the nucleus, and rest epinucleus and other management is same like other methods. So this is a slightly even denser cataract which I am showing. Again, the similar technique is used. You can see sideways trenching. I am doing gentle separation of these pieces without dividing the central part, which is taken out last. So once the 4 quadrants are there, I will just nudge them into the anterior chamber without any again rotation, and just emulsify them, and then finish the rest of the surgery. So this is a novel technique which can be used for posterior polar. You can go back to the part. In posterior polar cataract with denser nucleus, because that really poses us a challenge. Can you go? Shift. Go to the next. Okay. The cases were uneventful and without any complication. In one case, there was small opening in the posterior capsule, but IL could be implanted in the back. So I have 1 minute. Or finish it. So to conclude, the innovative surgical technique provide nucleus division without distorting or exerting traction on the weak posterior capsule. It's a useful technique for posterior polar cataract with nucleus crosses grade 2 and more. Thank you.
Excellent. So lucky to ask you a question.
Thank you.
It's not a question actually. Is it that easy to sculpt sideways? Never thought of it.
Yes. In fact, it's much
even
easier.
If it's a straight tip.
Yeah.
Straight tip.
So even I tried it initially. This question was asked when I presented it first. So initially I tried everything with the Kelman tip and a torsional phaco. But later I tried with straight tip as well as with longitudinal phaco.
Okay.
It's definitely easier with torsional and angle tip. But it can be done even with the straight and with longitudinal. But longitudinal, it's slightly more difficult as compared to.
Is a 0 degree tip better, or a 45 degree tip is better?
Yes, sir. 45 or 30 both are fine with this.
Both are giving equal results?
Yeah, of course 45 will be easier to trench, but if you are used to trench with 30 degree, that is fine.
My question is that how it gives, what is the advantage of it?
Yeah, so normally
what I understand from your presentation is that you are avoiding rotation of the nucleus.
Yes.
But so, when you are successfully doing double trenching, one straight and one sideways, you are having 4 quadrants.
Yes.
But when you are pulling up each quadrant in the anterior chamber or mid plane, you are having the same risk.
No,
unless you leave the epinucleus plate or some amount of cortical matter back there.
Yes. So if I analyze my videos with great denser nucleus with posterior polar cataract, the most common place where the nucleus starts sinking is when you try to rotate the nucleus. If you notice in the video, I never tried to do the the regular rotation. I just pulled the nucleus to the center, that quadrant, and emulsified. So it avoided that complete rotation of the nucleus, because if there is a adherence of the PPC with the posterior capsule, what happens? The rotation will tear that posterior capsule. That is avoided. Of course, if like in one case there was a capsular opening, but idea is we emulsified all the nucleus before there is a risk of any
drop. Do capsular hydrodissection, only hydrodelineation?
No, hydrodelineation. So all other steps will be standard steps. Thank you, sir. Thank you.
Yeah, you have a question? Go ahead. Posterior polar always remains googly for everyone.
Good morning, chairpersons, ladies and gentlemen. The title of my paper is High Dissect, a new surgical technique in the management of posterior polar cataract. The authors have no financial interest in the subject matter of this presentation. As you know that posterior polar cataract is a surgical challenge due to its associated high incidence of intraoperative posterior capsular disruption. Routine phaco forces, even any attempt to detach the cataractous plaque from the posterior capsule, may lead to complete pre-extraction disruption of the posterior capsule. Incidence of the PCR has been put 36 to 40% by most of the surgeons. Various techniques have been described to deal with the posterior polar cataract, but most of these techniques, they deal with the type 1 posterior polar cataract. That is a simple posterior polar cataract where you have a posterior capsule which is intact. There is a fragile and weak and brittle posterior capsule, but it is very adjacent to the plaque but not fused with the plaque. So there won't be any defect in the posterior capsule. But these techniques, they do not deal with the type 2 posterior polar cataract, that is complex posterior polar cataract. So what is complex posterior polar cataract is where the posterior capsule is firmly fused with the cataractous plaque. There is a pre-existing capsular defect or hole. There could be a segmental or complete agenesis of the posterior capsule. There could be anomaly extension into the epinuclear complex, and in no way we can prevent the posterior capsular disruption in these cases. So purpose of the study is to describe efficacy of a new surgical approach, that is high dissect, in the management of complex posterior polar cataract. Secondly, in minimizing the risk of further disruption of the posterior capsule and prevent the posterior segment complications, and also in prevention and pre-extraction of the posterior capsular disruption. We took up 22 cases of posterior polar cataract from our center during 2016 to 2018, and we grouped them into two groups, the simple and complex posterior polar cataract. Complete preoperative evaluation was done in all the cases, including the biomicroscopy, entry-segment OCT, spectral microscopic examination, fundus fluorescent angiography, and posterior segment OCT. All the 10 cases of complex posterior polar cataract underwent the high dissect, that is a new surgical technique in the management of these cases. So what is high dissect? Is a bimanual irrigation and aspiration cannula controlled dissection, separation and extraction of the cortical matter, epinuclear membrane, polar cataractous plaque, and simultaneous posterior capsular rhexis creation. So this is the video which I am going to show you. So you have to do a good inflation of the anterior chamber and do a small video is not playing again. Video is not playing.
Can you play that, sir, separately from the?
I don't know. So generally, actually, this problem comes up. So that is the reason. Look, the laptop should be allowed, I think, because most of the time, most of the cases I've seen presentation, the video is not playing.
All the videos had a problem.
So
You're right.
we can use our laptop and present very nicely. So now the problem is coming up here again. This happened many times.
Can you play from there directly?
Even ASCRS, they allow the laptop, but here I don't know. Okay, so this is a video. You have to do a small capsular rhexis of around 5 millimeter, and you should avoid cortical cleaving hydrodissection, but I do small segmental hydrodissection, which the wave should not go into the posterior capsule, and do a good hydrodelineation. Because most of the time the cataract is very soft in these cases, you don't have to much bother for the nucleus emulsification. Nucleus in generally, you can very simply take it out from the capsular bag and rotate, because since you have already done the nuclear delineation also in the beginning itself. The most important point is how to detach the plaque from the posterior capsule. You should not detach, you should not get into the problem of posterior capsular disruption before you extract the capsular component, and this is what I'm trying to do now, using both the irrigation and the aspiration cannula to aspirate the cortex before I'm tackling the central plaque. So central plaque should be left for the last to be removed, and once you have removed the cortex, then you start tackling this plaque. You have to go from the periphery and try to hold with the aspiration cannula and put traction on the center without going into the center first. Slowly and slowly you remove the epinucleus plaque which is attached to the center plaque of the polar cataract, and this is how, but leave the center in the beginning, and then finally you can hold the center plaque and try to put traction and remove this center plaque. So what you have seen now, you can see the posterior capsular defect, which has not disrupted further the defect which was already there in the beginning. And finally, you remove the remaining amount of the cortex and the epinucleus, fill in the capsular bag, and then put in the IOL into the capsular bag itself. So this was the first post-op picture of this particular patient. You can see the central capsular axis and the posterior capsular axis also. So this video was in short actually, because I haven't shown the full video because of the time constraint during the paper presentation. The last slide I want. So these most of the cases were in the age group of 20 to 40, because this is the time when these cases would present for the clinical symptoms. With the clinical symptom for the surgery they would come, and these are the parameters we recorded, and the results, as you can see here, we could do successful PCC in almost 90% of the cases, and we have been able to put in the bag IOL in 90% of the cases. And the vision recovered almost 20/20 in 60% of the cases, and 20/40 in almost 90% of the cases. So to conclude, bimanual low vacuum controlled aspiration of the cataractous plaque while creating a controlled posterior capsular axis is the most suitable surgical approach in the management of type 2 complex posterior polar cataract to prevent pre-extraction disruption of the posterior capsule and to prevent the possible potential complications of the PCR. Thank you very much.
Thank you, sir. What was the controlled posterior axis? Once that is aspirated, the natural defect is the posterior axis, right? Okay.
See, actually, because the plaque, as well as when there is a adhesion of the plaque to the posterior capsule as well as to the epinucleus, it's very soft. You cannot hold it with the forceps as you do the capsular axis for the anterior capsule. So only way out to hold that plaque and the epinucleus is to hold with the aspiration cannula. This is the best.
But the posterior capsular axis that you have mentioned, how you have not done it. It is the natural gap that is left behind, right?
No. That was the traction posterior capsular axis. It won't happen otherwise.
When you are aspirating,
otherwise
you are
there
trying
will be a
to make
disruption.
it a axis.
So I'm trying to put the traction capsular axis, because I'm holding the plaque as well as the edge of the plaque, and then trying to create a capsular axis by putting a traction on it. So that was the idea, so that you don't get into the problem of the complete disruption of the posterior capsule.
My question is that your preoperative assessment of type 1 or type 2, you determine which technique you will adopt, or you do always a high dissect in all cases?
100% you have to do the preoperative. That is why I have stressed on the preoperative evaluation. With the OCT is the best way to know that whether the capsular defect is there or not.
I understand. That means when it is type 1, you don't do it.
Type 1 you don't need, because the plaque is already away from the posterior capsule. In type 1 you don't need. It's only the type 2 where the plaque is adhered with the posterior capsule. When there is a complete adhesion, see, whenever you are doing you must have seen the previous video, the posterior plaque was not attached to the posterior capsule. You have a very thin and fragile posterior capsule, but it is not attached, not adhered. It is a type 2 where the plaque is adhered with the capsule. Then you find the problem.
When you are aspirating for the final rexus, does it happen that just part comes out and then you are left with a gap, which would anyway will be there, but not really a nice circular rexus? Because that's very fragile.
Very good. Very good point. Actually, what happens, because we used to just hold the plaque and take it out. Then what would happen if you have a previous defect in the posterior capsule, pre-existing defect? You will have a complete disruption of the posterior capsule. The tear will extend to the periphery and you will start having the vitreous and all. But with this technique, you know that there is a defect. So you are very slow, and very slowly you are trying to remove the plaque, putting traction and creating the rexus. I've done almost 20-25 cases by now. This was the presentation which I did in 2018 cases actually. So,
right. Yeah. Any questions?
Thank you.
Thank you.
Thank you very much.
Thank you, Dr.